Laura Parisi, whose name we saw in a couple of the slides, and Aarushi Singh Negi are both in Dr. Helen Bronte-Stewart's lab, the neuromodulation lab, and they're talking a little bit more about the spring study. And after they speak, and their talk is brief apparently, after they speak, we'll also have Elena Smith talking about a pilot program for connecting through art. It's a pilot program. I think it's next Friday morning. Yeah, next Friday at 11 a.m. There's still some spots available, so I asked her to come talk about that. So Laura and Aarushi, take it away.
Okay, thank you for the introduction. So hi everyone, my name is Laura. I'm here with Aarushi today. We are both research assistants within the Bronte-Stewart lab. And so Dr. Bronte-Stewart went over kind of the background of the studies that we're doing. So today we're going to be talking further about our Stanford Parkinson's research in neuromodulation for gait, otherwise known as our spring study, as well as our quantitative digitography study, both of which are open for enrollment. Our study utilizes a closed-loop neurostimulator, which can decode complex motor behaviors related to slow arrhythmic gait and respond to abnormal brain activity by adjusting stimulation. The spring study is our first clinical investigation into the safety, feasibility, and efficacy of neural and closed-loop STN DBS for gait impairment and freezing of gait. So there are two aims of the spring study that are completed over the course of the study visits. The first is to assess the feasibility of bilateral subthalamic nucleus neural adaptive DBS, driven by neural markers of gait impairment and freezing of gait. And this uses control policy algorithms that adapt DBS intensity at two different frequencies. And then the second aim is to assess the safety and tolerability of adding subject-specific doses of dopaminergic medication in combination with the neural adaptive DBS controller. For this particular study, we are working with patients who are already implanted with or are intending to be implanted with the Medtronic Percept PC as part of their Parkinson's disease treatment. Percept is a commercially available DBS system. The figure on the right shows BrainSense, which is an FDA-approved interface that allows us to record neural signals. Our study uses an investigational DBS software for which our clinical and research teams have received FDA approval to adjust closed-loop settings. This is what Dr. Bronte-Stewart was mentioning earlier about the how it has the research settings within, but it is locked for research purposes. And so if your primary care is outside of Stanford, our study doctors will be working in collaboration with your local neurologist regarding potential stimulation changes that may be different from your existing clinical settings. So this slide outlines the study timeline for the Percept PC protocol. All subjects will proceed through phone screens and in-person assessments to determine and confirm study eligibility. These participants will be enrolled following their surgical implantation with the device. Subjects will also participate in a signal check with the Percept device prior to study enrollment to ensure sufficient strength of beta band power needed to drive the neural adaptive controller. Following study enrollment, subjects will undergo technical checks to ensure patient safety, establish tolerable subject-specific ADBS parameters, and aid in the collection of artifact-free data in future research visits. Following technical checks, subjects will begin formal research visits evaluating NADBS at 140 Hz and NADBS at 60 Hz, or an equivalent frequency for the Percept device. 140 Hz is the usual clinically used frequency. 60 Hz is used less often, but as mentioned by Dr. Bronte-Stewart, has shown evidence to be effective for gait. The neural controller will be tested in both a harness stepping in place or SIP task and an unharnessed walking task known as the turning and barrier course or TBC. Each of these research visits will take place over the course of 3 to 4 days or more if needed for patient comfort. The order of the two neural adaptive DBS conditions will be randomized across subjects, with the SIP visit always preceding the TBC visit, such that we are evaluating the neural algorithm in a bench-to-bedside manner. The Columbia Suicide Severity Rating Scale, CSSRS, New Freezing of Gait Questionnaire, NFOG-Q, and Unified Parkinson's Disease Rating Scale 1 through 4, also known as UPDRS 1 through 4, are to be administered the first day of each visit off medication to monitor suicidality as mandated by the FDA and disease state. The NFOG-Q evaluates frequency and severity of freezing of gait, and the UPDRS is a comprehensive 50-question assessment of both motor and non-motor symptoms associated with Parkinson's disease. At TBC visits, repetitive wrist flexion extension, RWFE, and speech testing will also be administered at multiple time points to monitor other symptoms like bradykinesia, tremor, and speech. Both the UPDRS-3 and custom adverse event AE questionnaires will be administered at several time points within each visit for SIP and TBC to monitor for safety and tolerability between conditions. After the successful completion of in-clinic testing, participants can proceed to an optional long-term NADBS protocol if they elect to do so. So here is a more detailed overview of the long-term neural adaptive DBS testing protocol. Participants will begin at a baseline visit where they will complete assessments and questionnaires in their current clinical open loop settings. During baseline testing, the CSSRS, NFOG-Q, and UPDRS 1 through 4 are administered the first day of each visit off medication. The UPDRS-3 and custom AE questionnaires will be administered at several time points within each visit to monitor for safety and tolerability. The quantitative assessments will include SIP, TBC, RWFE, repetitive alternating finger tapping, otherwise known as RAFT, and speech testing. Following the completion of the baseline visit, participants will be randomized to start in either the neural adaptive controller or on open loop. At the end of the visit, the participant will be sent home for 2 weeks on their first randomized condition. In the first condition, the participants will return at 2 weeks and at 4 weeks for in-clinic testing. Baseline assessments will be completed on the first day of each in-clinic visit. The UPDRS-3 and custom AE questionnaires will be administered at several time points within each visit, as well as quantitative assessments including SIP, TBC, RWFE, RAFT, and speech testing while on medication. After the end of the 4-week visit on the first condition, the participant will be switched to the other condition. The participant will then follow the same protocol. Following completion of the protocol for both conditions, the participant can elect, in conjunction with their clinician, to continue on NADBS stimulation if it is found to be of comparable or better efficacy as open loop. These settings can be continued until the study ends or the therapy is approved by the FDA. If the participant elects to continue on NADBS, they will be asked to return every 3 to 6 months for an in-lab assessment to monitor safety and tolerability until the study ends or the therapy is approved by the FDA. If a participant elects to continue on open loop stimulation, they will be exited from the study. So now I'm going to hand it off to Aarushi, who will discuss inclusion/exclusion criteria.
Thanks, Laura. So this slide shows some of the main inclusion and exclusion criteria for the study. Overall, we aim to recruit participants who have gait impairment and/or freezing of gait, who are implanted with or intending to be implanted with the Medtronic Percept PC DBS neurostimulator system. It is important to note that even if you only have some gait impairment, such as slowness when walking, but don't experience freezing, you may still be eligible for the study. However, you do need to be able to walk unassisted for the gait tasks that will be done as part of the experiments. As our study is funded by the NIH Brain Initiative UH3 grant, you can find more details on clinicaltrials.gov. In addition to our spring study, we are going to transition into our study about quantitative digitography, which is a remote method of quantifying and tracking motor symptoms in people with Parkinson's disease. Currently, standard methods of providing care for people with Parkinson's disease are inefficient. Neurologists have consistently made up only 2% of physicians, while the number of individuals with neurological disease increases exponentially. Due to this imbalance, over 50% of people with Parkinson's disease do not have access to a neurologist. For those who do have access, there are 3 to 6 month intervals in between visits, and currently there is no way to monitor or get data about a person's response to therapy and/or progression during those long intervals. Our solution uses quantitative digitography or QDG technology, which provides objective validated measures of the major motor signs in Parkinson's disease from 30 seconds of repetitive alternating finger tapping, otherwise known as RAFT, on a digitography device. In this visual, you can see a patient performing a guided RAFT task on the Key Duo. The data from this task is then transmitted to a HIPAA-compliant server and is analyzed by our algorithm, which produces validated measures of all motor signs of Parkinson's disease, such as rigidity, bradykinesia, tremor, gait impairment, and freezing of gait in real time, which a healthcare provider can use to make complex management decisions with quantitative validated data. The study we are currently recruiting for is called the Quantitative Digitography for Assessing Movement in Neurological Conditions. The purpose of this study is to upgrade and validate a portable computerized piano keyboard or Key Duo to objectively quantify movement in people with symptoms of neurological disease. Our research visits will be approximately 60 to 120 minutes long, in which participants will perform a series of finger tapping tasks and answer questionnaires related to the task and the Key Duo device. We are also transitioning to at-home testing, where you would be able to use the QDG system in a remote setting. Please feel free to contact us at these emails or through our lab phone number. You can also find more information on clinicaltrials.gov or centerwatch.com. Lastly, we'd like to acknowledge our current and previous team members who have made vital contributions to the work we presented here today. Thank you all for your time.
Great. Thanks very much, Laura and Aarushi. Appreciate that. And I put in the chat a blog post about the spring study. And if Aarushi, if you or Laura would send me the information about the Key Duo study, I'll post about that as well. So just to be clear, the Key Duo study is available for normal healthy controls, so-called normal healthy controls, right?
Yes, we are looking for people who have Parkinson's disease or who are healthy controls as well.
Okay, perfect. And then the spring study is available only to people who already have or intend to have soon the Medtronic Percept DBS system.
Yes, that's correct.
Great. So everybody on this call should be eligible for one or the other of those studies, or maybe both of the studies. So hopefully people can participate. Appreciate your help. I don't know if, here, one question came in. Contacts for CDG. I think that's for the Key Duo study. So maybe, Aarushi, could you put in the chat the contact information for the two studies? The one study, the spring
Yes,
study, it is on the blog post, but you might as well go ahead and put it in the chat as well. Okay, any more questions? I see no more questions in the chat. Okay, or the Q&A. Great, thanks you two very much.